fortunately. I could see her that her speech was getting slurry, and she was drooling. I was aware of the signs of stroke.
Ladies and gentlemen, thank you for being with us today. Today's session is an extra special session because in today's talk, we are not only going to be listening to doctors and health providers. Today's session is a little bit different. We are trying to engage with one of our patients whom we have recently seen. And we want you as the audience to witness live or in the words of the patient what this patient has gone through and how her journey has been. This session is being prepared as a way of raising advocacy for stroke. 29th October is regarded as the World Stroke Day, and we are preparing this video to try and raise awareness about stroke. In today's session, we have two special guests. One is Anisa. Anisa is our patient whom we had treated recently, and she is here with her son Hassan. Now, Anisa is special to us because she comes from Kenya, so she is our guest, and guests need to be taken special care of. She has some difficulties in communicating in English or Kiswahili, so we will try and ask her some questions in a language that she understands, and then we will ask Hassan to kind of translate what she's trying to say. So, Assalamu alaikum.
Alaikum salam.
Anisa and Hassan, thank you for being here with us today and sharing your story. So, the first thing that I would like to ask you is, why are you here? Why are we here today, and what are we discussing?
Last month muke stroke tyo. To ajawi da awi se ke munjo dokter ke disa.
Today we are here because of a doctor visit. She got a stroke on last month. Okay.
So, can you tell us your story? Can you tell us 1 month ago when you got that stroke, what happened?
Membasa ti awi se. Baca ke nareli. Ida munjo baca meri hidai. Ta bas racu ida wita asis di rumah. Hi musa te wito Adil. Adil ida wito, ni Hasan ida wito. Ta chanda sate ram divisi. Pardivisi noha ta ancora di santi che munjo zaban bari tio. Kabarna koro tio pan nati boli saga munjo zaban bari tio. Ta Hasan juko ida wito inja baki bola itu Adil angalia mama sunanti pan muka kabarna koro tio. Tapo ricorso nanti che in mere prescianti via che c'entra allo ospital me kabana ma che corotio herte son divisi ambas poi muke nichu sundi khani via poi ambulance avio muke ambulance me charae ta amere sunanti panki panati ikrohat nai pak nai mu nai.
So she said that she came from Mombasa to visit us. So we were sitting in the sitting room. She was making play my daughter, small daughter, and I was with her, fortunately. I could see her that her speech was getting slurry, and she was drooling. I was aware of the signs of stroke. Those are the major signs. You have a blurred, slurred face. So I told my brother, let's check. He checked. her face went to one side, and one arm and one leg wasn't functioning. We tried to make a stand, but she couldn't. So we called the ambulance. The ambulance came immediately, like 5 minutes. Took 5 minutes for the ambulance to come. Then we took her to the hospital.
So Hassan, if I can ask you, how long did it take for you to get to the hospital?
Approximately 20 to 30 minutes. We are at the hospital already.
So what was the rush? Why did you have to rush so fast?
Because it's a stroke. It needs less time.
So can you tell us when she reached the hospital in the ambulance, then what happened?
Once we brought her here, the doctor asked for a CT scan. We take her for a CT scan. We immediately took her to CT scan. Then we brought her back. Then the doctor confirmed that it's a stroke. We need to give her a media injection to thin the blood. So we gave her the injection for blood thin.
So when this injection was given, then what did you see?
When first we brought her, before the injection, her one side wasn't moving at all. But after the injection, within 20 minutes, we could see improvement. Her legs started moving. And in the next 24 hours, even the hand started moving.
Okay. So if I ask you, today is 1 month since she got the stroke, right? You brought her to the hospital, she was given some medicines. How do you compare her when she got the stroke and today?
I don't see any difference right now, because before we brought her, there was no movement. Right now, alhamdulillah, everything is moving. Her face has come to normal, almost normal. Her hands are moving, legs is moving. She's independent right now.
If I may also say that where we are recording is on the 2nd floor, and she managed to climb the stairs herself. Alhamdulillah. I think that was great. So if I can ask both of you, Anisa and Hassan, there are people who are listening to your story. What is your message to everyone?
My message is to be aware of signs of stroke and need to act quickly. The faster you act, the better. With my mom, we brought her to hospital within 4 hours or less than that. That's why we can see a big improvement.
Ankit, you want to tell us something? Any message from you?
जिको भी बीमारी होते आए बेहतर का आए कि भले जल्दी भी हॉस्पिटल में ताकि इनके दवा मिले.
Just say it's when you get this thing, it's better to come to the hospital immediately.
Okay. So Anisa and Hassan, thank you for sharing your story. Anisa, you are a stroke survivor. Okay. The problem of stroke, the common knowledge out there is that when someone gets a stroke, then they are going to be bedridden for life. They are going to not be able to walk for life. There are nice and important treatments that are available, but it is very important for the patient to come to the hospital early and on time is when these treatments can work. So the message that we are trying to convey to everyone out there is this famous phrase which is called time is brain. Okay, the earlier you come, the larger the amount of brain that your doctors can salvage and protect, and that is very important in regaining functional capacity later on. Once again, we thank Anisa and Hassan for joining us and sharing their story, and we wish that she continues to recover even more and more as the days are going. We also wish to bring about this important message that please know the signs of stroke as they occur, and then when you see those signs of stroke, please rush your loved ones to the hospital so that the right treatments can be given. Wassalamun alaikum wa rahmatullahi wa barakatuh. Thank you.
Yes. That's being here first.
Hello. Hi, testing. Okay. Is it audible? Okay. So, very good evening to all. And on behalf of MCure Pharmaceuticals, so we'd like to welcome all the delegates whomsoever joined for today evening session. And along with us, we are having a interesting, topic from the faculty side, Dr. Manji and Dr. Mois. So I think there is no need of introduction, among these two faculties because they are well known. They are very much academic and passionate toward teaching. And though it is our honor to have them in our MCure platform, and MCure CrossTalk was created because we wanted to have interaction between different specialty doctors and to give them the overall, outcome where we can able to save the life of the patient holistically by seeing all the sides. So that's the main objective of creating this MCure CrossTalk. And Dr. Moise Adamji, I should appreciate him. He is continuously supporting our programs, and previously he has done 2-3 programs with us, and this time we wanted to do it on a neurology side. So we have Dr. Manji, and I would like to introduce our faculties for today. Dr. Manji, he is a consultant physician and a neurologist at Ibrahim Haji Hospital, Dar es Salaam, Tanzania, and he is trained a neurologist from Muhas and Apollo Hospital, Hyderabad, India. He is an early career researcher in stroke and other diseases like HIV, tuberculosis, and acute kidney injury from malaria and polytrauma. He is also a member of Tanzania Neuroscience Association and Tanzania Epilepsy Association. He is also an adjunct faculty at Internal Medicine Department, Mugas. So welcome Dr. Manji for today's session. And we like to introduce Dr. Moise Adamji. He is an emergency physician and head of the Department of Emergency Medicine at Shifa Pan Hospital, African Hospital, Dar es Salaam, Tanzania. He is passionate about teaching and organizing CMEs as an educative initiative. He is also an instructor for BLS, ACLS, ITLS at EMSA. And Dr. Moise brings an energy, leadership, and a deep passion for saving lives at critical care and emergencies. Welcome, Dr. Moise Adamji, for today's session. So over to Dr. Moise and Dr. Manji. Thank you.
Okay. All right. Good evening, everyone. It's almost time, and the introductions have been done. But I would like to say that this topic is very important, not only for medical professionals like me and you, but also for the community. And we have seen time and time again that 80% of people from our community, they don't know what is a stroke, and they don't know what are the symptoms. And even if they find out that someone has a symptom of stroke, it ultimately they don't reach on time. So we are doing what is called as normally physiotherapy and rehab rather than actually treating the stroke. So here we have Dr. Manji with us, and we all know that he has been a pioneer when it comes to stroke care, as well as his achievements in neurology speaks for itself. So without further ado, let's welcome Dr. Manji, and we shall have a presentation on thrombolysis from him, after which we'll have some chit chat, and we'll see if he can answer all our questions and queries. So welcome, Dr. Manji.
Thank you, Moise. It's really a pleasure to be here today. The task at hand is perhaps among the most difficult things that we are going to talk about when it comes to management of patients with stroke. I'm really thankful to Moise and Arun and MCure for having me here today. And I will try and share my 2 cents on the subject. And then perhaps we can see in our discussion if there are any questions, if we can answer them, and try and do our best to improve the levels of thrombolysis that are happening in the country. Okay, so I will just load my slides and then we can start. So we decided to call this topic ischemic stroke. Let's thrombolyze together. And we know that stroke is a huge subject, and basically it has a hyperacute component, an acute component, and then the post-acute phases of stroke. And in this particular webinar, in this particular crosstalk, I have decided to kind of narrow this or channel this into ischemic stroke. So number one, we are not for this webinar going to talk about hemorrhagic strokes. We may touch on them, but the idea behind this webinar is to really look into the acute phase of the ischemic stroke. And then the second line says, let's thrombolyze together. Moise has had sessions with cardiologists. He had with Dr. Kuzema before, where he was talking about acute myocardial infarction and thrombolysis in myocardial infarctions. Now, the common practice out there is that there is more thrombolysis happening for MIs, but perhaps not as much happening for strokes. And that is an interesting phenomenon because both are emergencies, both have infarcted tissue, and both require revascularization. So I am going to take the road less traveled, okay, and going to talk about stroke acutely and what we can do or what information really is required so that doctors out there, emergency practitioners out there, general practitioners out there, physicians out there can thrombolize strokes, okay, so that the outcomes actually improve, right? Now, it is a cross-cutting discussion, and we will try and tackle it slowly, one step after another. And when I start, I'm going to give you 3 case scenarios. These are real cases that I have seen in my practice. The first case that I'm showing you, this is an elderly gentleman who presents with sudden onset of right hemiparesis and aphasia. And he comes to you, to the hospital, 30 hours after the onset of his neurological deficits. And then a CT scan is done, and there is a large left MCA stroke, okay, a bad one. This is case number 1. He comes to you 30 hours after symptom onset. Then I'm going to show you the second case. And this is a 60-year-old female, okay, with sudden onset of facial droop and mild right arm weakness. And her symptoms actually began 2 hours ago. Yeah. So you can see the difference between the first case and the second. The first one is presenting to you 30 hours after the onset of the stroke. The second one is presenting to you within 2 hours of onset of stroke. And the third case scenario is, you will have guessed this by now, is someone who will have presented to us anywhere between that 4.5 hour period to the 24-hour period. So the third case is someone who also has a stroke and now presents to you after 16 hours of onset. And the common thing between all of them is all of them have strokes, but the different thing between all of them is that they are all presenting to you, the healthcare provider, at different points in time. Yeah, and there is some technicality, there are some differences about how you would manage each one of them in terms of the time at which they present. So I will throw this piece of research at you. This is a study that was done in the Lake Zone, so around Manza area. And in this study, we looked at patients who came to us with stroke, and you will see the red box at the bottom. And actually what you will see that the majority of cases that come to us, doctors, after presenting with stroke, the majority of them, they come very late. They come more than 24 hours later. So they behave like patient number 1, right? And then those who present very hyper acutely, those who present very early, they are few, okay? And according to this work that we did, it's about 4 to 5%. And then there is that middle area where after 4.5 hours to 24 hours, there is another something like 18-20% that present in that period of time. So you will understand that when I talk about thrombolysis, I am actually talking about those few 5% that come to us. And that is why I mentioned at the beginning that I am talking about the road less traveled, right? Because it will be easy to say that if it is a minority, okay, then why do we have to take so much energy and kind of target a minority while there are a majority who are coming late? So I understand. I agree that there is a large amount of work that needs to be done to get them to the hospital on time. But for that case that comes to you on time and you do not provide them guideline directed treatment, then that is a big mistake, right? And that costs the patient a lot of morbidity and a lot of mortality. So in my talk today, I'm going to go through a roadmap, okay? And I am going to share with you the questions that I ask myself when a patient is presenting with a stroke to me. So the first question that I ask myself, is it a stroke, right? You have to ask yourself that question, is it a stroke? Because only when you identify it is a stroke is when the hyperacuteness or the emergency nature kind of settles in, kind of sinks in, right? Once you have answered, once you have said that it is a stroke, right? Then the second question you're supposed to answer is, how severe is that stroke? The third question you are supposed to answer, okay, it is a stroke, we know the severity, is it ischemic or is it hemorrhagic? And after we know whether it is ischemic or hemorrhagic, we need to know in what window this patient is presenting. If it is within the time window, okay, then there is an indication for thrombolysis and we need to work energetically so that we can thrombolize them. But while we are energetically working to thrombolize them, we also need to be aware of the contraindications, certain conditions which would contraindicate the use of thrombolysis. Then we want to now thrombolize this patient. So you have to ask the question, what molecules are available at my disposition which I can use? And what is the dose? And once I have given, that is not the end of the story, okay? Then how do I monitor this patient? And once I know how I monitor this patient, there are other emergency or other crucial interventions that are important for a patient with stroke other than thrombolysis, which we also need to look at. Yeah. Now, please do not misunderstand what I'm trying to say. Thrombolytics are powerful molecules. They are like fire. When you use it right, you can cook your food. When you use it wrong, you can put your kitchen on fire, right? So what I'm trying to say is that know who is the right candidate for you to use your thrombolytic. Please, by no means, do not misunderstand this webinar to kind of motivate everybody that now whenever a stroke comes, I'm just going to use a lot of alteplase or tenecteplase. That is absolutely not what I'm saying. I'm saying patient selection is crucial, and in this talk, I'm going to take you through that. So the first question you usually ask yourself is it a stroke? So for you to know whether it is a stroke or not, you need to be able to know the definition of a stroke. So a stroke definition has three components. It has to have a sudden onset of neurological deficit, okay? And the cause has to be vascular, okay? It has to be sudden onset of neurological deficit and the cause is vascular. You have to fulfill these three criteria for it to be called a stroke.
Recording
and
in progress.
You fulfill that criteria, you have to tell yourself this is a stroke and it is a medical emergency and I need to get my adrenaline rush. Yeah. And again, quickly speaking, very briefly speaking, we have ischemic strokes and hemorrhagic strokes. And for the matter of this discussion, we are going to talk about ischemic strokes. When I talk about stroke, I think I also need to talk about this important entity called transient ischemic attack. If you take a group of doctors and you ask them the definition of a TIA, they will tell you that it is reversible neurological deficit that reverses within 24 hours. This was the old definition, which was a time-based definition. whereby we want to kind of see the reversal of the symptoms within a 24-hour period. The challenge is that the time window for thrombolysis of stroke is 4.5 hours. The time window, if you use this old definition, whether it is a TIA or not, the time window was 24 hours. So if your patient presents to you early, if he presents to you at 3 hours, you are left with a question. You are either praying to God, this is a TIA, and within 24 hours it will resolve, okay? Or you will let the 3.5, 4.5 hour window pass, and you will not have done anything, and you will have lost the golden hour, right? So for that reason, we are now using a tissue-based definition. So in a TIA, usually the neurological deficit lasts for just few minutes. In most studies, it doesn't even last 1 hour, okay? So any deficit that has kind of extended beyond a few minutes to hours, it is much wiser to think of it as a stroke rather than to think of it as a TIA that is going to resolve, and then it doesn't, and then you have lost your golden hour, right? So please, this is a very important message. We are moving away from a time-based definition of TIA. We are moving towards a tissue-based definition of TIA, whereby a TIA is very, very transient and very, very brief. And the problem with the TIA is that although they are self-reversing, they bring bad news, because a TIA today means a stroke tomorrow. Yeah, and you really need to pick it up. So because we are talking about strokes, and we are saying that strokes are vascular, of vascular origin, then we cannot run away. As much as people out there, doctors out there, don't want to talk about neurology and neuroanatomy and the circle of Willis, you cannot run away from the circle of Willis. So I have shown you diagrammatically what the circle of Willis is. It is basically an extensive anastomosis of blood supply at the level of the brain. It is, we divide, if I draw a horizontal line somewhere here, sorry, okay, then what is in front of this line, we call it anterior circulation, and what is behind this line, we call it posterior circulation. And the anterior circulation comes from the internal carotid artery, which branches into the middle cerebral and the anterior cerebral artery, right? The ACA and the MCA. The ICA branches into the MCA and the ACA, and this actually comprises the anterior circulation. The posterior circulation is actually the vertebro-basilar circulation, the vertebral artery and the basilar artery, and then eventually these will now join with the anterior circulation. So we have anterior circulation strokes if they occur in this territory. We have posterior circulation strokes if they occur in this territory. Now, there is one terminology that is very, very important, and you will understand the importance a little bit later. And that terminology is what you call LVOs, large vessel occlusions, right? So strokes can occur with restriction of blood flow across any of these blood vessels. But when that blood flow is impaired in one of the major areas, so for example, if the ICA is blocked, or the proximal part of the MCA is blocked, or the proximal part of the ACA is blocked, the area of infarction in the brain is very, very huge. And these are really devastating strokes. And these are called large vessel occlusions. So you now know that there is something called stroke. These are ischemic and hemorrhagic. And then the ischemic strokes, okay, they could be anterior circulation or posterior. But when it involves a large area, a large caliber blood vessel, we call them LVOs, large vessel occlusions. It's very important to know them because there is a technical aspect about it that needs a bit of discussion, okay? And there is an interesting finding that we found when we looked at some strokes in Tanzania. We found that about 30 to 40%, okay, of the strokes that we get in our setting, there is reason to believe that they may be large vessel occlusions. Now, this study that we did had a bit of limitations because for you to know whether it is large vessel or not, you need to look at vessel wall imaging. So you need a CT angiography.
And in this study, we did not do a CT angiography. We did normal non-contrast CTs. Okay, but still with the way the nature of the radiologic findings are, there is still strong reason to believe that we have between 30 and 40% of strokes occurring in our setting, which are large vessel occlusions. And now that we have identified that this is a stroke, right? You have fulfilled that criteria. It's a sudden onset in your patient, is a sudden onset, is a neurological deficit, and now we know the cause is vascular. Then we come to the symptomatology. And usually the acronym that is used is FAST, okay? And now there has been modifications to the FAST, and it is called BFAST. And BFAST means there is sudden onset of either balancing issues, sudden onset of eye problems. This could be either gaze paresis or ophthalmoplegia or something like that. You can have face deviation, okay? You can have paresis of half of your face, okay? You can have arm weakness on one side, slurring of speech, your speech may be affected, okay? And when you see these signs, the last letter T represents time, represents the emergency. It is now time to make that phone call, right? It's now time to either call your ambulance or to call your loved one around to take you to the hospital, right? So this is be fast. Now, strokes, the brain is a very complicated organ. And depending on where the strokes are, so many signs can occur, right? So the be fast is actually an oversimplification, if I may say so, because it just wants you to pick up the large majority of strokes that occur. But there are other strokes in other areas that may present in different ways. But suffices to say that if the be fast is followed, okay, we will pick a large majority of strokes. And to also emphasize this point, I think before this webinar started, there was a video that was playing, okay? The FAST acronym has now been validated into Kiswahili for our local context, okay? And the Kiswahili acronym is called UPESI, okay? FAST, okay? Matching with UPESI, okay? Where U stands for uso kupooza, so that is your face weakness. And then the P stands for kupooza mguu na mkono, mguu au mkono, au mguu na mkono, okay? And then the E meaning eleza, ugumu wa kuelezea au kuongea, okay? And then the C, the SI represents simu, right? Piga simu. So if you spot these signs, okay, piga simu, okay? This is an emergency, something needs to be done. This is a study that is validated in our setup, okay? Now, it's important to say that while you are entertaining a diagnosis of stroke, right, there are some other things that also mimic strokes, right? So you have hypoglycemia, and you have seizures, and migraines, and vertigo, and with the art of history taking that you are taught, okay, eventually these need to be ruled out, okay? I'm not going to take too much time into that. I think it suffices to understand that mimics need to be ruled out. So we have finished one. We said that we are going to ask 10 questions. So we have finished question number 1. We are now going to question number 2. If it is a stroke, then we need to know what is the severity of that stroke. And to know the severity of that stroke, we use 2 scales. We use something called the NIHSS, the National Institute of Health Stroke Scale, and the MRS, the Modified Rankin Scale. The Rankin Scale is easy to understand. It is from 0 to 6. It is a functional scoring. You are scoring your patient's pre-morbid state, right? Before he got the stroke, this person, what was his functionality? Was he up and about? Was he going about his daily activities? No symptoms, that was a 0. Or the level of disability, right? 1, 2, 3, all the way. And 6 means someone who's dead, right? So it's a functional score. And the NIHSS, the NIHSS, on the other hand, is a more organic scoring, whereby you have to score a patient from 0 to 42, whereby 0 means no deficit, okay, and 42 means extremely severe deficits, okay, and you grade that stroke according to the severity. So anything less or equal to 4 would be a minor stroke, right? And the thing about NIHSS is that it has 11 segments. It has 11 questions that need to be answered. ranging from level of consciousness to gaze, to visual problems, to face deviation, to arm deviation, to leg weakness, to ataxia and incoordination, to sensory abnormalities, language dysarthria, and finally neglect, right? These are 11 kind of set of questions that we need to answer. And as difficult as it may sound while I'm saying it to you here, with some training, not intensive training, very similar, very simple training, there are online websites which can train you for free how to score this score at the bedside, without any investigations, without any expensive tech or anything else required. At the bedside, you can score your patient to give a score to the stroke that they are having, right? And it can be done in less than 10 minutes, right? We know that time is brain, and we really want to kind of rush. So this, with a bit of practice, it can be done in 10 minutes or less, okay? It is used to monitor the neurological status of the patient. So you will need to have a baseline value, and then you will need to have kind of a monitoring later. And it predicts the functional recovery and the mortality risk after ischemic strokes. And what is actually peculiar is that the stroke is better scored by EMTs, emergency physicians, and emergency doctors who are receiving the patient rather than neurologists who are sitting in their office, right? So that's a very important message to get through, that these strokes, okay, these NIHSS scores are actually better done by the people who are receiving these patients. So it should not kind of worry us that this is a very difficult thing to do. It is fairly simple. And again, the good news about it is that the NIHSS has also been adapted into Kiswahili, okay? This work has also been done, and there is a Kiswahili version of the NIHSS that is available. You have now answered two questions, okay? You have answered whether it is a stroke, this patient is having a stroke. You have answered whether it is how severe. The third question you want to answer is whether this stroke is ischemic or hemorrhagic, right? And for the purpose of today's discussion, we want to look at ischemic strokes. Now, if we are talking about a patient presenting to you with stroke, the objective of imaging is, primary objective of imaging is only to identify whether it is ischemic or hemorrhagic, in the sense that if you do a CT, in the hyperacute phase, the only thing you are looking for is whether there is a hemorrhage or not. A hemorrhage that would perhaps contraindicate the thrombolytics that you want to use, okay? Now, just engage with me for a little while. When we talk about ischemic strokes, the picture that most doctors will draw in their brain is that stroke with that big hypodensity sitting on the CT scan. Dear colleagues, that picture only appears when the stroke is established. Okay, this is those strokes that come to you late. If there is a stroke that is truly presenting to you on time, it will probably look like a normal CT scan to you. Okay, so an acute patient presenting with neurological deficit and you see a normal CT, it does not mean that there is no stroke. There still is a stroke happening, because the diagnosis of stroke is a clinical one. In the hyperacute phase, the CT just helps you to rule out a hemorrhage, okay? And that is a very important thing to understand. So that's the primary role of your imaging, okay? There are other things that the imaging may show. It may be able to tell you, depending on what imaging modality you are using, if there is some salvageable penumbra, or whether the stroke etiology, whether it is embolization, but we don't want to go into that. The first and the most important role of imaging is to make sure whether it is a hemorrhagic stroke or ischemic stroke. Having said that, it doesn't mean that there are no signs. But the absence of these signs does not mean there is no stroke, right? That is very important to understand. And I think I'll show some pictures. This is a patient presenting to us in a hyperacute state. And if you have just a gross look at it, this looks like a fairly normal CT, except that there is some haziness around this insular area, okay? And if you look at this CT, this also looks fairly normal, okay? Except that if you compare the right side and the left, you will see that on the right, you can see the caudate and the lentiform nucleus, but on the left, you can see the caudate and the lentiform is hazy, right? These are very subtle signs, subtle obscurations, okay, that happen because of the hyperacute state, right? There is something called the hyperdense middle cerebral artery sign, and you will see in this picture here, for example, you will see this hyperdensity in the region of the proximal MCA, and that actually represents a clot, right? That represents a clot sitting there. So you have a patient with sudden neurological deficit, and you do a CT, and you see a hyperdense MCA, okay? That is alarming. That means that there is a stroke going to happen. This is an angiographic sequence that shows you the MCA cutoff on the left, while a normal MCA on the right, okay? And this kind of hypodensity, this large hypodensity that you see, it is quite rare to see this in the hyperacute state, okay? If you see someone presenting with this hypodensity that we all know about, right? Please question yourself if this patient is truly within time window or not. Please question yourself, because this represents a very large area of necrosis that tells us that this infarct is established. It may be of a long duration, okay? And that means that thrombolizing this patient, it may be risky because there is a lot of necrotic brain that may hemorrhage. The other thing that we do when we are doing a CT scan is something called the aspect score. This is, in a very simple language, it is Alberta stroke score. We call it the Alberta stroke score. And the radiologist can help you, but if you also look at the CT scans and develop the habit of looking at the CT scans, this is not a very difficult thing to do. Basically, we are going to look at the CT scan at two cuts. Those of us who are familiar with CT scans usually are a rolling video, right? You scroll down and slide after slide, you keep seeing different cuts of the brain. So you need to go to a cut which is at the level of the basal ganglia and identify some structures there. So you identify the caudate, the internal capsule, the lentiform, the insula, middle 1, middle 2, middle 3. Then you scroll with your rollerball and you go a little bit higher. You go to the supraganglionic level. So this is the level of the brain where now this basal ganglia cannot be seen. Okay, you can see the ventricles, but the basal ganglia cannot be seen. And you identify M4, M5, and M6. And if you kind of count all of them, they are 10 in number, 1 till 10. These are 10 regions. And basically, every patient who has a suspected stroke, when you do a CT scan, you give them a 10. You say, I'm giving you a 10, okay? And then as you are looking at the CT scan, you are looking at the level of obscuration in each of these territories. And for every territory that is obscured from that 10, you are going to remove 1 point, right? So for example, if someone has obscuration in this area, this area, this area, the others look all fine, then 10 minus 3 will make 7. So I'll show you. So this is how the CT scan would look. This is at the ganglionic level. You can see the caudate here. You can see the lentiform nucleus here very well. So you will identify those areas, and then you will scroll up to a higher level. And now you cannot see the basal ganglia, and you will identify your M4, M5, and M6. And in a hyperacute state, okay, perhaps the scan will look like this because the stroke has just occurred and they've rushed to the hospital and really time has not gone for these areas to start getting obscured. Compare it with this patient, okay, who comes to you and you do a CT scan, and just at a quick glance, you'll be able to say that the Alberta score here, if 10 is the best and 10 is normal, this guy has lost quite a few, right? So he has lost 1 point here, 1 point here, 1 point here, 1 point here. So this guy is scoring maybe a 4, okay, out of 10. So it means the lower the number, it means the more established that infarct has become, right? So you want to know on the CT scan if there are any signs of hyperacute stroke. and you want to know on the CT scan the Alberta score, because the Alberta score tells you how established that stroke has become. The more established that stroke has become, the more risky it may be to thrombolize that patient, because it is necrotic brain, okay, and it may bleed. And that brings us to our fourth question, and that question is it within the time window? Yeah, and it's important to ask this question, because when we talk about the time window, when you have an area of the brain that is infarcted, there is an immediate region that dies. We call that area the core. The area outside the core that is surrounding that core is called the penumbra. When a patient comes to you early, there is a core and there is a large penumbra. A penumbra is a metastable region where blood flow is less but not totally zero. It is a potentially rescuable, a potentially salvageable tissue of brain. So, for example, in this case, if you look at this patient who comes to you 10 minutes after the onset of stroke, the core is very little. The penumbra is huge. If you give this patient time and do nothing, what will happen is that that core begins to expand, and eventually 6 hours later or a period of time later, that core and penumbra change into a core altogether. And the challenge with that is that if it is core altogether, there is nothing to rescue. Then it means whatever thrombolytics you want to give, there is nothing to rescue. So really we want to catch them early so that they have a small core and a large penumbra. Okay, so someone coming to you with an aspect score of 10, think about it, with an aspect score of 10, it kind of gives you an idea that although the stroke has happened, you are seeing the symptoms, but because hypodensities are not appearing, probably the penumbra is large. However, if you see something like this, okay, if you see someone who has a stroke like this probably means that the core has now become established and all of that is just dead brain material, okay? And that is why we say time is brain, okay? Time is brain. And this concept of time is brain emerged in the 1990s with a trial called, a very famous landmark trial called the NINS trial. And in that, within 3 hours, when patients were given alteplase, okay, then there was a 70% increase in functional independence. And then later on, another trial came, some 10 years later, another trial came that kind of expanded that time window from 3 hours to 4.5 hours. This is called the ECAS-3 trial, okay, and that kind of showed that up to another 4.5 hours, okay, you can also salvage a lot of functional independence, okay. But these studies, they also showed us something. They said that that window rapidly closes, right? So we have the 3 hour window and we have the 4.5 hour window. And I think now universally, everywhere around the world, we use the 4.5 hour window, okay? That window closes very rapidly. And that is what this graph is trying to show, because beyond the 4.5 hours, okay, this graph is actually approaching the null line, okay? So really that 4.5 hour window is the golden hour that we really need to try and target so that we can lyse our patients. And just to give you an idea of how quickly that window closes, if you thrombolize someone within 90 minutes, you need 1, 2, 3, 4, 4.5 patients for one patient to receive the benefit. But if you wait for your 4.5 hours, okay, that 4 patients actually becomes 16, right? So you've lost a lot of brain material just waiting from kind of 90 minutes to 270 minutes. So the point is, 4.5 hours does not mean if someone is caught at 2 hour point, then you wait till 4.5. Try and get him as early as you can to thrombolize this guy. I know this is not without difficulty. And that's why I said I'm talking about the road less traveled, but this is the crux of it. Now, remember those cases that I showed you, those 3 cases that I showed you. And there was that case number 3, which was really a thorn, isn't it, under our skin, where someone is presenting now to you after the 4.5 hour window, but before the 24 hour window, right? So what can we do about them, right? And then I also told you that there is this concept of what we call large vessel occlusions. Now, these large vessel occlusions, they are so catastrophic, right? The deficits in them are so significant, right, that there has been a lot of work to try and see if those large vessel occlusions can be revascularized. And the way that they can be revascularized is by endovascular treatment. Okay, so this is an endovascular therapy, which means something like what the cardiologists do, right? They go angiographically, endovascularly, they reach all the way to the brain, and then they can suck out the clot, right? Now, this is endovascular treatment. There are trials that have been done that have showed that there is a lot of potential in this treatment, provided a lot of criteria are met. And I'm saying this again with a lot of caution, that you need to really meet a lot of criteria for people to kind of benefit. But because we are talking about revascularization, then it is important for everybody to know that thrombolysis is not the only method of revascularization. There is thrombectomy or endovascular treatments, okay, which kind of confer a lot of benefit. So this is what I'm trying to show here, that traditionally we were talking about TPA and kind of thrombolytics to lyse the clot, but now as time has progressed and there are newer imaging modalities, okay, there is now this role of endovascular thrombectomy to kind of take that clot out. Just to give you a sense, this patient has an MCA that is occluded, and then the clot is removed, and then you can see that he has been reperfused, okay? So an ideal thrombectomy candidate would be someone who has an LVO. So not all strokes will go to the neuro lab, right? To the cath lab. So those who will go will be those who have a large vessel occlusion, and either this will be the ICA, the MCA, or the basilar artery. In some centers, they do up to the basilar, but usually it is the ICA and the proximal part of the MCA. We have reached step number 5. Your patient is now on time. You have done your CT scan. You have scored him. You have made sure it is not a hemorrhage. You know that it is ischemic. He is within the time window. Now we need to thrombolize him. So when you diagnose acute ischemic stroke and CT negative for hemorrhage, and he is within the 4.5 hour window, that patient meets the indication for thrombolysis. If you have a patient like this and you do not thrombolize, you are liable, because it confers good benefit, right? And if you want to thrombolize, then obviously you need to know what conditions would contraindicate thrombolysis, right? So for example, if the patient has an intracranial hemorrhage, this is an obvious, right? You do a CT scan, you see a hemorrhage there, you're not going to thrombolize that patient. Or any other hemorrhagic kind of manifestation, subarachnoid hemorrhage. If you are thinking about thrombolizing your patient and they have very high uncontrolled blood pressures, they need to be lowered down a little bit, okay? And we'll talk a little bit about that. Or any active internal bleeding, or any other conditions that predispose this patient to a coagulopathy or a bleeding kind of tendency. And then these would contraindicate your thrombolysis, okay? Then you ask your question, which thrombolytic should I use, okay? And over a course of time, since thrombolytics were first identified in the NINS trial, the alteplase, really there are so many studies that have been done that have looked at, the earlier studies all looked at alteplase, and now the newer studies, they are looking at tenecteplase. And really, one is not much better or worse than the other, right? I think that is a very simple, straightforward conclusion that we can make. One is not better than the other. I think we used the rationale of COVID vaccines, right? When everybody was asking which COVID vaccine is good, the Russian one or the Chinese one or the American one, we told them the best vaccine is the one that is in your shoulder, right? So if you have one of these thrombolytics available to you, okay, then either one of them is equally okay. Tenecteplase has some aspects of it that make it a little bit preferable, but really it is not about selectivity. It is about whatever molecule you have, try and salvage that brain that you are trying to salvage. So we talk about the dose now, okay? We have one of the two available. Now we talk about the dose. So please remember that when you want to administer your thrombolytic, please secure 2 lines, okay? one line dedicated for the thrombolytic, and then another line for any other intervention you're trying to do. Okay.
I think one more thing about the lines. Many people think in emergency pink lines are okay.
No,
it should be green lines.
It's green.
And I don't know if my students are hearing, but it should be green lines, not pink lines.
Yes.
Okay.
Large caliber lines. Okay. So you need to have two, one for your thrombolytic and one for any other intervention you're trying to do. Okay. Try and keep your blood sugars less than 10. Hyperglycemia is associated with worse outcomes, and blood pressure. Now, we are talking about ischemic strokes that are within time window. We need to bring your blood pressure down a little bit to about the 185, 110 mark. It has to be below this mark. If it is higher than this, okay, then there is a chance that that thrombolytic may cause hemorrhage. Okay, so please try and bring your blood pressure down to 185 by 110 or slightly lower, okay, before administering your thrombolytic. Okay, now remember, I'm talking about a hyperacute stroke. I'm talking about a stroke that is within time window. If you have a stroke presenting after, it is coming after the 4.5 hour mark, but before the 24-hour mark, it is still an acute stroke, but the candidate is not, the patient is not a candidate for thrombolysis. In that scenario, our blood pressure target is a little different, and I will talk about it in a bit. Okay. And if whether you are using tenecteplase or alteplase, alteplase is a 0.9 milligram per kg. Maximum dose is about 90 milligrams. 10% of that is given as a bolus, and then the remaining 90% is an infusion over 1 hour, right? So it takes 1 hour for the whole thing to finish. Okay, then you give a saline flush. Tenecteplase is 0.25 milligram per kg. Maximum dose is 25 milligram. You do not go higher than that. The dose of tenecteplase in MI is double that, right? So this one we are trying to, the dose is less, right? So please take this important point. In MI, people are giving up to 50 milligrams or higher. So here it is half of that. Okay, so please be careful.
And now there is an availability, right? I heard that tenecteplase is available in 25 milligram form as well.
Yes.
So you don't have to go for the 50, 20 milligram actually.
Yes.
And you don't have to go for the 50, which is expensive compared to this one.
Yes. So what was happening is that the 50 milligram vial was designed for MI.
Yeah.
And if you have a patient with stroke, then there is half vial that you are throwing away. Yeah. And that was kind of a waste. So now we have a dedicated stroke vial of alteplase. Okay. Now, important to know that alteplase does not go well with dextrose. So please be careful of the fluids that you are running before or after giving your thrombolytic. So a saline or a Ringer's should be okay. And then now we have reached question number 9, right? We have given our thrombolytic. Then what do? We need to monitor, right? Because what we have done is we have tried to reperfuse this patient. If we have tried to reperfuse this patient, it means there is a good chance that occlusion has now opened up, okay? So do not try that your blood pressure never goes higher than 180, okay? The hemodynamics, the cerebral autoregulation mechanisms change because now you have achieved a bit of reperfusion. So you will still be higher, but you will not go beyond 180. You will put the patient on monitor and do not do any invasive procedures. Don't do any A lines, okay? It's not really required. We are also discouraging catheterization, okay? Do not catheterize these patients, okay? I think it is, do not give your aspirins now. At this point, you do not give your aspirin, you will give it later. Okay, so you give 24 hours later, and then your nursing team is extremely important because they will do all the vital signs and the neuro assessments, and your doctor who is there in the stroke unit who is taking care of this patient. You will now monitor your blood pressures. Different ICUs have different protocols, okay? And not only the vital signs, you will also monitor the neurological status of this patient, okay? You will determine the level of consciousness, your GCS, your pupils, you look at your pupils, and the NIHSS, which is a continuing thing because you want to know if there are fluctuations in the score. The two common things or the two important things that we need to watch out for are one, hemorrhage, and the other one is angioedema. Now, when we talk about hemorrhage, when patients get a stroke, there is a 3% risk of hemorrhage of that stroke turning into hemorrhage spontaneously, even if you don't do anything. There is a 3% risk, okay? With TPA, that risk goes to about 6%. So you need to explain the family that there is this real risk that is there, but given the time window and given the correct patient selection that you have done, okay, the risk is probably manageable, okay? And again, remember, keep your blood pressure slightly lower, okay, because very high blood pressures may cause a hemorrhage. And then the angioedema, okay? And that occurs, is an allergic response, occurs to less than 1% of thrombolyzed patients. And if they are on ACE inhibitors, then the risk is a little bit higher. So for hemorrhage now, we are looking for signs that the hemorrhage is occurring. We are looking for headache, we are looking for nausea, vomiting, and we are looking for neurological deterioration. And what you do is, if it is TPA, which is an infusion, you will stop it, right? You will stop it where it has reached. Okay, you will inform the doctor who is on the ICU shift and try and obtain another CT brain to see if there is a hemorrhage, okay? And discuss reversal options. If it is angioedema, okay, you will notice swelling of the face, the lips, the throat, the tongue. There may be some difficulty swallowing, some hoarseness, and some tingling sensation around the mouth. Then please inform the doctor who is there on duty. And here now we are talking about airway compromise, and you may need to go for an intubation, right? Depending on the scenario. Moise knows more about this than me. And then there are kind of histamines or anti-allergy medications, diphenhydramine, solumedrol, and epinephrine that may be given, right? And you have done it, right? You have identified your patient, you have scored him, you have made sure it's ischemia, you have made sure he's within window, you have lysed the patient, you have monitored the patient for complications. At the end, apart from reperfusion, there are some other crucial interventions that are important in patients with stroke, and I must mention them. If you look at this chart, this very heavily burdened chart, you will see that there are different interventions over time that have been advocated as management for ischemic stroke, right? Among all the interventions that are there, the intervention that has been found to have the highest benefit and that benefits all patients with stroke is treatment in a stroke unit. Okay, nothing trumps that. Okay, aspirin cannot trump that. Your TPA, your thrombolysis, the benefit that you give cannot trump that. And the answer is, and the reason is that stroke units are available for all stroke patients, right? TPA and thrombolytics that we are giving are there for a subset of patients, right? It will help those minority who come on time, right? But stroke units are there for everybody. Anyone who comes with an acute stroke is potentially eligible to go into a stroke unit, okay? So a stroke unit is a very, very important thing that you will do for your patients with stroke, whether they are early or late. And this is actually just a multidisciplinary team, right? And every person doing their job, keeping the patient at the center, right? Everybody doing their job. There will be the pharmacist, there will be the nurse, there will be someone for speech, there will be someone for occupation, there will be the social worker, there will be the physio, there will be someone taking care of the diet. All come together, do their roles, and eventually assist the patient. And when patients are within stroke units, it really helps bring down the mortality of such patients. And actually, I have put this here on purpose because this is an official document, okay, from the Ministry of Health of Tanzania, a document that was released in 2023, about a year and a half to two ago, that kind of mandates establishment of stroke units among all major hospitals in Tanzania. So to have a stroke unit should not be an option. It should be an important thing that we do for all our patients who come to us with stroke, no matter where we are, okay? The other crucial intervention for patients with stroke is blood pressure control. And this is usually an area which is very heated, okay? That gets a lot of questions and a lot of confusion. With patients who have acute stroke, if they are a thrombolytic candidate, okay, you want your blood pressure. If you are a thrombolytic candidate, you want your blood pressure slightly lower than 185 over 110. Okay, you don't want very high uncontrolled blood pressure. But if your patient is within the acute phase, but is outside the thrombolytic window, we are permissive. Okay, we do not mind if your blood pressure goes up to 220 over 120, right? Because of the cerebral autoregulatory changes that are occurring, you just observe. I commonly say this, those who are my students will know, when we are in medical school, there is a gentleman called Guyton who wrote a famous book on physiology. And he mentioned that normal blood pressure is supposed to be 120 over 80. And when our interns and our junior doctors see a patient presenting with acute stroke with blood pressure of 180, okay, they remember Guyton. They remember that Guyton said normal blood pressure is 120. So the intern or the doctor who is seeing the patient wants to use a lot of energy and try that bring that blood pressure down to normal, what he thinks is normal. In acute stroke, we want to have a little bit of permissive hypertension because that promotes cerebral blood flow and prevents secondary injury around the penumbra. Okay, so unless it is catastrophically high, please leave it alone. And by that I mean anything that is more than 220, okay, and diastolic of up to 140, right? I mean, that is catastrophically high. You will bring it down a little bit. Okay, we say about 20 to 25% reduction. Okay, and you will use a molecule that is available to you. Again, the COVID vaccine principle. Okay, there is no choice. Okay, the studies out there do not look at the molecules that bring the blood pressure down, they look at the blood pressure targets. Okay, so if you have labetalol available for you, please use labetalol. I have labetalol available for me. I frequently use labetalol unless there is an explicit contraindication. The other important crucial intervention you will do in patients with acute stroke is to control their sugar. And we want to avoid both extremes. We want to avoid hypoglycemia and we want to avoid a blood glucose more than 180. Okay, so a good window is between 140 and 180, and insulin is usually the preferred treatment for that. Yeah, and that actually applies even for patients who are not diabetics. If you have a non-diabetic patient who is having a hyperglycemia or a hypoglycemia, please keep it within that window. The other crucial intervention, we call it FESS, F-E-S-S. F-E stands for fever, S stands for sugar, and S stands for swallowing, right? So these are things that you will monitor and kind of manage. You don't want a hyperthermia or a hypothermia. You want to monitor and keep your sugar within that level, and you want to assess for dysphagia early and intervene, okay? Because you can cause aspiration pneumonia in a patient whom you have not identified. And we are trying to discourage the use of indwelling catheters in acute stroke, okay? Unless there is a real pressing indication for you to use a catheter. They have been caused to cause a lot of urosepsis that actually causes a lot of morbidity on patients with stroke, right? So up to this point, we have covered the 10 questions that you ask yourself, and if you answer each one of them correctly at the end, you will have a successful thrombolysis, hopefully. Okay, so I will stop there. It's been a long talk, and we will now kind of discuss, right?
Okay. Sharing, Zoom. All right. Okay. So, do we have any questions from the audience before we start discussing and do the actual EM crosstalk?
I wonder if there are questions on the chat box.
Yeah, that's what I was asking. I think the host can tell us. By the way, this event is hosted by RX Events. They are from India and they do this frequently for corporate clients. So if anyone is interested, you can directly communicate with us.
Yeah, there is one question
Okay.
from Dr. Ali Munir Agrabi.
Dr. Ali is my favorite person.
Yeah.
He always asks question. I love it. I love it.
Okay. So if it is hemorrhagic stroke, is it not allowed to reduce to even less than 140 by 90 millimeter mercury? And should we leave at 220 mmHg? Intract 2 study.
I'm trying to talk about ischemic stroke in today's kind of webinar. Okay, and what I have mentioned is please it is for ischemic stroke. For hemorrhagic stroke, the recommendations are slightly different. You will keep it at about 140. You don't want to bring it down all the way to 100 or 110 or 120. So 140 is a reasonable kind of a mark. Okay, for your hemorrhagic strokes, acute hemorrhagic strokes.
So I have some questions. And the first question was, you see, we in emergency medicine, we get patients whose time of onset is not known. How can the MRI help us in identifying or knowing the time of onset? And how can that help in determining whether we should thrombolize the patient or not?
Okay, Moise wants to take me there.
Yeah.
Let me give you an example. There is this terminology which we say last known well. Okay, in stroke, if you call me and you want to consult with me regarding an acute stroke that you have, okay, I will fight with you on the phone if you do not give me a last known well, because it is the last known well that is used to identify the onset of the symptoms and to tell you really if you are within the time window or not. So I'll give you an example. We know that many strokes, I think this is not a new thing, many strokes occur when people are asleep. Yeah?
Yeah.
So they have their meal, they have their evening dinner, okay, and then 10 o'clock they go to bed, okay, and they went to bed, they were in their usual state of health, and they go to sleep, and when they wake up in the morning, okay, if they waking up for prayers, usually people may either wake up to go to the bathroom, okay, so at 7 o'clock they wake up, it's a Monday and we have to get to work, and they realize they can't walk, they're falling down, and one side is paralyzed. So at 7 o'clock he woke up, yeah, and this patient is now brought to the hospital. The relatives see he has fallen down. It's 7 o'clock in the morning, okay, by 8 o'clock they're at the hospital, okay, doctor, this is a stroke, okay, and I asked them, when did this happen, okay, just now at 7:30. That is not correct. For that patient, the last known well is 10 o'clock at night when he went to bed. The stroke happens sometime in between, and that time of onset is indeterminate. Okay? In that case, the last known well is at 10 o'clock. So we have a stroke of unknown onset, right? If we have a stroke and someone has lost consciousness on the street and someone finds them and brings them to the hospital, it's a stroke of unknown onset. Now, a stroke of unknown onset, unknown time of onset, is a little bit different than the strokes that we have discussed. I told you that everything revolves around the ischemic penumbra. Whatever we want to do to salvage that ischemic penumbra. Now, with evolving technology, we now have MRI scanners.
Yes.
And the MRI scanners have some special sequences.
Yes.
There is something called the DW sequence, and there is something called the flare sequence.
Diffusion flare.
Yeah, diffusion weighted sequence and then the flare sequence. Now, the diffusion weighted sequence is a sequence that picks up hyperacute strokes, even seconds to minutes long. You will see a signal in that sequence.
Yeah.
And then you have a flare sequence that will only start picking up signals if certain number of hours have elapsed. So if I see a patient with a stroke of unknown onset, and then I do an MRI, and I look for something called DW flare mismatch. What that means is I see a signal on DW, but I do not see a signal on flare. It means the DW is picking it up. It is early. The flare is not picking it up, so some hours have not passed. So it means that DW flare mismatch tells you that there is a penumbra there, okay, that is potentially salvageable. Now, while I'm giving you this concept, and I'm telling you that MRIs are now becoming more and more available, they are still not as easy to access in the acute setup.
Yeah.
So we have our own set of limitations, and the test of choice, the imaging modality of choice in acute stroke still remains a non-contrast CT. Okay, let me not say that the MRIs have replaced the CT. Okay, so in expert hands, in neurologists' hands, when an MRI is done and they can do all this dilly-dallying and kind of finding out if there is a penumbra or not, we leave it with them. For the general knowledge of the audience today, right? Non-contrast CT brain, as soon as possible. That is the message.
All right. Okay. The second question would be, we talked about the NIHSS score, right? So I've heard that 4 to 25 is what you would use to thrombolize the patient. Is there an exception? Like, let's say if my score is less than 4, but I have a facial droop, or I have a speech defect. Is there any guidelines or recommendations saying that, oh yeah, you can still thrombolize such patients?
The NIHSS score is used to mark the severity of the stroke, is not used to make decisions.
Okay.
What is used to make decision, okay, one, it is not a hemorrhage, and two, it is within time window. Okay, that is what is required to make your decision about thrombolysis. Now, there is this terminology which we call TIA/minor stroke, right?
Okay.
So these are entities which we call them from 0 to 4.
All right.
Okay, so TIA technically will reverse, so the score will go back to 0, and then a minor stroke will have up to 4. Okay, and these ones are treated a little bit differently because first of all, you need to give them dual antiplatelet. They will not the guidelines do not recommend monotherapy. You have to give them dual antiplatelet, right? So it is a little bit of a different category in which if it is a score of 2, for example, you have an NIHSS of 2, then perhaps the risk of thrombolysis may be, the risk of hemorrhage post-thrombolysis may be higher than the deficit that this patient is having. But I must also caution that the name of the game is monitoring. What could be NIHSS 2 now, maybe NIHSS 4 half an hour later, maybe NIHSS 10 1 hour later. Okay, so it's about monitoring and just trying to be hyper alert and see what's going on.
Is there any question?
Yes, doctor. You can mute because it's mute. It's echoing.
It's a?
Yeah, I will read the question.
Okay.
Yeah. And Dr. Manji, there is a question from Dr. Eric Thomas Temba. Is there a role of thrombolytics in patient with a transient ischemic attack? And he also asked that, is there a role of doing a lab investigation such as prothrombin time and INR before giving thrombolytics?
Pandora's box. Okay. Technically, TIA is a reversible entity, and if you have been following your TIA and it is not resolving up to about an hour, you are better off calling it a stroke and thrombolizing rather than praying to God that it will be a TIA 4 hours later. Okay, so I think that if you think it is a TIA, just follow it. Usually, most TIAs will resolve very, very quickly. TIAs technically do not meet the indication for thrombolysis. Okay, so if it is a TIA and meets the definition of TIA, please do not thrombolize this patient. Okay, tests, the PTINR and everything. Actually, there are only 2 things required before you make a decision to thrombolize. The first thing is your NIHSS score, and the second thing that you require is a blood glucose test. And I'm saying this, I'm not unaware of the risks of thrombolysis. I'm aware of the risks of thrombolysis. You see, these things are happening simultaneously. You are taking a history simultaneously, okay? And the value that these additional testing and the time that they take pose on that penumbra is really big, right? So if you have done your due diligence, you have taken your history, you have done your best, okay, then it is okay. You can go ahead, and these tests can be done side by side. Because when you say PTINR, the quickest lab that will do a PTINR for you will be, I don't know, a few minutes to an hour, okay, or more maybe. I don't know, Moise, what do you think? How much time does it take with your place?
It depends on the lab to lab, but
Yeah.
You can fasten it at least by 30 minutes maximum.
If you have a point of care INR,
Yeah, then that's
perhaps, but I don't work where I have a INR point of care, right? And again, remember, guidelines are guidelines, and we really need to kind of fine tune them to our setup. Okay, so I think that if you have done your due diligence, please don't worry so much. If your patient selection criteria is right, you shouldn't worry.
And doctor, one more question from Dr. Hasnian Rustam. And what is your experience with the elderly suffering more ischemic or hemorrhagic? As per old teaching, most elderly gets ischemic only.
Maybe we should do a research on it.
Actually,
Or is there research?
okay, this is a difficult question to answer because I'm probably answering it from my experience rather than from some concrete scientific study that has been done. In for example, for my case, I'm a neurologist, and referrals of stroke will come to me from all over the place, right? People will refer ischemic strokes, hemorrhagic strokes. So in my experience, I see both of them. Okay, if I'm going to take a bet, I would say I see a little bit more ischemia than I see hemorrhage. But again, I do not have numbers for that. Is what I can say. But the other problem is that a lot of researches that are done among stroke patients, the eldest of old are usually an exclusion criteria. So they are not even captured in those studies that are being done, right? The age gap would be anywhere, so adults all the way to about 60, 65, 70. So the eldest of old are usually an exclusion criteria when you're writing your proposal. So they may not be captured. So I really don't have that data to kind of give it to you.
And doctor, there is another question from Dr. Ismail Sange, and he is asking about what is the dose of tenecteplase in ischemic stroke, considering high NIHSS score.
The NIHSS score is just the NIHSS score is just there to give you a severity of the score. It does not influence your dosing. Your dosing is based on weight. It is 0.25 milligram per kilogram, and you dose accordingly.
The max is 25.
And the max is 25. You don't go above 25.
Okay. So in terms of stroke pathways, what is your take on a stroke pathway? Because our hospital has one. I know Seifi has one, Aga Khan has one, and we are all using borrowed creativity to make a similar one. And I believe it's working well because every time we have a patient like that with BFAS, we activate the stroke code. We will call our neurologist. Our neurosurgeon will also be there. Sometimes he gets angry that why you calling me, but we also call him. Radiologist is informed, and everyone else who is involved is there. So we time it immediately, and everyone is rushing. So anytime there's a code stroke or code chest pain, we are all running around like a headless chicken just to make the time work. So what do you think about that?
I think if you don't make a pathway for stroke, stroke is contributing such great morbidity and mortality to the community, and they will come, right? So a code stroke is very, very important, and I think that it is motivation and determination that is very, very important. For example, the place where I work does not have a CT scanner. Okay, so if I am going to follow the preset algorithms and the preset pathways of do this and do that are set about in European or American guidelines, it will not work for me because where I work, there is no CT scan. So I have to find an innovative way whereby I will, because we are using a satellite approach, right?
Yeah.
Like a hub and spoke model,
Yeah.
right? So the patient has to go from our place to where a CT scan can be done,
Yeah.
and back. And I have to do it within 4.5 hours.
Yes.
It's crazy. I think we are running not only as headless chickens, we are running as headless everything.
Yeah, definitely.
So really you as the doctor who is listening to this, you know your environment. You know that time is brain, and you know what innovative things you need to do around your place. Okay, that is going to be important. There is an agency called the Angels Academy. Okay, they have some very good guidelines about how you can practically adapt such that you can kind of thrombolize your patients very early. So one example I will give you is when if you don't have a CT scanner on board, right, and you are going somewhere else to do a CT scanner, you tell your emergency doctor to get on that ambulance, go with the patient with the tenecteplase in his box, right? Go there, get the CT scan done, and once the CT scan is done, it's not about returning the patient. The patient will come later. The thrombolysis is done right there at the CT scanner, right? And that is something that you will innovate based on the need that you have.
So speaking about innovations, like in America, European countries, they have a truck of a CT scan. And when a code stroke is immediately identified by the paramedic, that truck can go to that patient. The CT scan is done there. And if thrombolytics are supposed to be given, they can also be given on the way before the patient reaches the hospital. That's how innovative other countries have been. And now there is portable CT scan from Siemens, by the way. They've started, they came up with a portable one. And that was something new for me as well. So innovations, yes, like you said, is it there? And I think it's the job of also, if we had a pre-hospital workup. Now this is for our association, Emergency Medicine Association of Tanzania, Muhimbili, that they have to pull up their socks, and now they have to work on that pre-hospital workup that we are doing in the back end, obviously, but we have to move fast because we have the ambulances. And if EMS is strong, then I'm sure we'll never go to a hospital which doesn't have a CT scan. We'll go to first the hospital which has CT scan. And if the patient is saying, no, I want to go to this certain hospital, then after the CT scan, they can go to that hospital or something over that line. So I hope that works out. And that is a key point. I mean, I think when it comes to when you have done ACLS, it talks about systems, whereby first system is identification. It starts with the community. So me as a doctor, I would go to my home and I'll tell my grandmother. I know she will not understand me fully, but she might understand me a bit of it. That she has slurring of speech, she should call me. Or she should call someone who will then call the ambulance. And I mean, I'm not trying to promote anything, but G1 is doing an absolutely wonderful job. That it's a free ambulance, yeah, and they're calling and all that. So you can call an ambulance. Let's start one there, and then after that ambulance, you take that person to a specific place for CT scan. So that's something that we could do, and it starts with the community. So I think internally, community, the government support, ministry support, and educating people about stroke, like the UPESI thing is amazing. That video was spot on. And those are the things which are required right now from us. So I believe that is something we should do. So last question would be, what is this term malignant MCA? And what does it mean? Like,
okay. A malignant MCA, so when people hear the word malignant, they think cancer. Okay? And maybe some of them are thinking that cancer is causing a stroke or something. What we mean by a malignant MCA is an MCA stroke that is highly proximal, right? So for example, it could be an ICA stroke, because if you have an ICA stroke, then you have your ACA gone and your MCA gone, right? Or you have a highly proximal MCA, and these strokes are catastrophic because they will involve a large amount of the brain, okay, and the amount of neurological deficits and the amount of neurological morbidity in these strokes is a lot. Now, I know why Moise is bringing this question up, because malignant MCA strokes are indications for hemicraniectomy, right? So these are because when you talk about stroke, you talk about medical management of stroke and you talk about surgical management of stroke, right? And when you talk about surgical management of strokes, one of the surgical things that you could do is to do a hemicraniectomy, which basically means removing half of the skull and keeping the brain relatively exposed. I'm not a surgeon, the surgeons will know this, but basically you're giving room to that edema to settle. Okay, now hemicraniectomies are the guidelines that are there, because we have to be guideline driven but also practical. I don't know how easy it is in our setup, right, to have a neurosurgeon available. But talking about the science of it, if it is an MCA stroke, okay, and if the patient is picked within 48 hours, early, okay, not when that whole hypodensity thing is already there, early, and is less than 60, then there is room for a hemicraniectomy, if you have the surgical expertise available. Okay, it's a hard thing to do. It's a really hard thing to do.
I think we have, if there are any questions, then we can answer them.
Yes, doctor. There is one more question from Dr. Graniel John Judge. For how long do we give dual antiplatelets?
Depends if you are asking a cardiologist or a neurologist. Okay, I will leave the cardiologist with their point of view. When we are dealing with two indications, a TIA or a minor stroke, please, it has to be a TIA or a minor stroke. Dual antiplatelets are given for 21 days. Okay, at the point of time of 21 days, you drop down your clopidogrel, and then the aspirin continues lifelong. Okay, so dual antiplatelets in a TIA or a minor stroke. So a minor stroke is NIHSS less than 4. In those other strokes that we see, the higher NIHSS scores, okay, it is just a single antiplatelet that is required.
Okay. And there is one more question. This was a debate that we had almost every time in our morning rounds. Can you give nitroglycerin IV to a stroke patient if you don't have any other medication?
May I ask Moise in what context he is asking that question? Moise is very cheeky. In the ischemic cascade,
Yes.
okay, among the different molecules that are released, okay, there are some molecules that they are reactive oxygen molecules and other second messengers that are downstream, okay, and nitroglycerin, GTN that is talking about, I think is a nitrogen donor, and that some theoretical concept is there that it may reverse some of the downstream pathways. It is not studied, okay, so it is not evidence-based. And I think in a public forum, we should be talking about evidence-based treatments.
So basically, I would like to avoid that drug whenever possible for ischemic stroke. And I would not want my students to use it, even if it's the only available.
So unless you're using, for example, if nitroglycerin is available to you and you're using it for blood pressure control, that's okay. The indication is blood pressure and not neuroprotection. Yeah.
Okay. Any other questions?
Yes, doctor. Dr. Gutimba, and he is asking about which type of stroke between hemorrhagic and ischemic has a good prognosis.
So which has a good prognosis, hemorrhagic or ischemic?
Yes.
Okay. Yes.
If I'm reading a textbook, okay, I will say that hemorrhagic strokes have a worse prognosis because there is a higher incidence of a lot of raised intracranial pressure and other pressure-related complications that happen. So hemorrhagic strokes generally tend to have a slightly worse prognosis. But by no means should that mean that ischemic strokes cannot be catastrophic. They can be quite catastrophic. Now, in our studies that we have done, there is actually a very surprising or peculiar thing that is happening. If we look at the work that we have done on stroke 10, 15, 20 years ago, okay, that has been done, it seems that ischemic is more than hemorrhagic. But now I think ischemic and hemorrhagic are occurring at the same level if hemorrhagic is not occurring slightly higher, okay? So some epidemiologic things are changing and they need to be looked at.
Any other?
Perfusion scan.
Oh, what is a perfusion scan? I was going to go there, but then I was like, let me control myself.
Advanced imaging modality, right? When we talk about advanced imaging modality, we have the CT scanners, the non-contrast CT scanners, and then now we want to go into a higher imaging modality. So one would be, for example, a CT angio, right? You give your contrast and then you look at the blood vessels. Then you can do something called a CT perfusion. And what that means is that on that CT scan that is there, if you guys know about if you have a pulmonary embolism, we do something called a VQ scan. There's something called a VQ scan. So using similar methodology, okay, the idea being that you want to identify the core and the penumbra. So a CT perfusion scan is an advanced imaging modality that tells you how much is the core and how much is the penumbra, just with the idea to find out if that core is bigger or the penumbra is bigger. You want a big penumbra and a small core to know that you have something to salvage, and your CT perfusion gives that to you. The other advanced imaging modality is your MRI, and whereby you can do your DW flare sequence, right, which we discussed about. Then there is also something called MR perfusion. Okay. Now, CT perfusion is not available in our setup. MRIs are available, but it may be difficult to access it in the acute setting. If you have a stroke at night, I would like to know that hospital which can do an MRI at night. It's quite difficult, right? And then MRI perfusion, these are additional modules that you will add on that MRI scanner that you have to get some few more additional sequences. But suffices to say, what we have is what we should use, right? We have a non-contrast CT scanner, we can do CT angios, right? And we can do an MRI. And we use those, and they're more than enough to make our decisions, if used correctly.
So we have 3 minutes to go. Do you have any questions?
Yeah, one more question came, Doctor, from Dr. Granville. Pediatric patients with a sickle cell anemia and stroke, can we give antiplatelets?
Pediatric stroke, another difficult area to go into. Okay, so let me first say that the thrombolytics are indicated for adults, right? If you have an adult presenting with an acute stroke, then thrombolysis is indicated. If they are less than 18, it does not have a unanimous indication. As far as antiplatelets are concerned, I think when a child, so I'm not a pediatric neurologist, and there are pediatric neurologists who are better able to answer your question. But if you are a child and you have had a stroke, we need to look for the cause, right? Because it is not it is probably an underlying condition. There is sickle cell, or there is leukemia, or there is something going on, and you look at that risk factor, and then you treat that risk factor. Some of those risk factors may have a role for aspirin. So, for example, if someone has hematological conditions like essential thrombocythemia or polycythemia rubra vera giving you strokes, okay, then yes, perhaps there is a role for aspirin there. Okay, so with pediatric strokes, you need to look at the cause, try and identify it, address it.
And Doctor, one more question. What are neuroprotection medicine post-stroke available in Tanzania to use?
Neuroprotective, okay.
Yes.
There is no high-level evidence neuroprotective molecule available till date. Okay, and I must make this very, very clear, because levels of evidence vary, right? They vary from high-level randomized trials to personal experience, right? So if I have given a banana to a stroke patient and he got better, in my opinion, maybe the banana helps. Okay, so the levels of confidence or levels of evidence vary. So in this webinar, I will say that there is no high-level evidence for any neuroprotective agent so far. There is a rigorous research that is going on to try and identify these neuroprotective agents. Perhaps something will be identified later, I don't know.
All right. Yes. Okay, so I guess that marks the end of our webinar.
Sorry.
Yes.
May I also just interrupt while we are talking about neuroprotection?
Yes.
This is extremely important, and I have to say this. Yeah. There is no role of prophylactic anti-seizure medication.
Yes.
Please, this please has to cut across, because patients who develop stroke are given some levetiracetam or some carbamazepine or itasaidia asipate dege. So please, there is no role. Those are not neuroprotective. Now, if you have developed a post-stroke epilepsy, perhaps that's a different issue. Then we can think about it, but not as a prophylaxis. And that applies to ischemic and hemorrhagic strokes. Okay, you need to get a seizure before you are started on anti-seizure medication. Do not give it just because you want to protect something or you want to treat yourself rather than the patient. Okay.
All right. So I would like to thank our sponsors, who was EM Cure, and EM Cure with it's not just about, this company is not just about selling their product, which is the Nectar Place, but they are actually into continuous medical education. I have always seen him supportive. Arun has always been there, and his whole company and team have really supported us. So on that note, I feel like this company deserves a round of applause from every one of us. And secondly, a round of applause to all of you, 400 of you who have joined online and made this event or talk possible. So it wouldn't have happened without your support. And thirdly, we should remember to be fast. Be fast, and also spread this word of UPSC and BFAS to your family, because it starts with you. You go and spread the word into the community will come back to you, ask you, hey doctor, BFAS is there. Okay, go and do a CT scan. And then finally you will reach that goal of giving a thrombolytic. So let's thrombolize together. And on that note, good night. And thank you everyone for supporting.
Yes. Thank you, Dr. Moise and Dr. Manchi, for the energetic and educative, session today. And I believe that all the delegates who attended, they have gained, a lot of knowledge from you both. And let us, connect this type of, platform to, have more such sessions for our delegates in upcoming days and weeks. And thank you so much for all the delegates who joined today. And we really appreciate